Hi, everybody, and welcome to the webinar today on received high protein foods and fluids and received oral nutrition supplements. It's a real pleasure to have you here today. My name's Jack Bell. I'm a dietitian in Australia and also a professor of nutrition in Iceland. I'm really looking forward to this afternoon's session where we've got some great speakers from different places all around the world. I think we've got nearly most of the global regions covered by our speakers today. And it's a really good topic that we have here. So I think we might almost get straight into it. If you just give me a minute, I'll just check um, where we're going. Is there another slide here, Katerina? Or is this? No. Great. Oh, sorry, I just lost it. Yes, so that was the conflicts of interest. It was pretty quick. All I'll say on that one is it's we are all members of FFN, Fragility Fraction Network, so that's probably our not conflict of interest, but our acknowledgement. I will say that Fragility Fraction Network does receive funding from a number of different industry partners, including Nutricia. We're pretty thankful for Nutricia for being an ongoing partner of FFN. However, industry partners, including Nutricia, have had no role in the design, development, implementation, or evaluation of the Simpler program. So, great. I see we've already got some people here who are on board. So it's great. If you're happy to, in the chat there, if you can just pop down your name and which country you're from and maybe your profession, if you're happy to do that, and we might get started with the program. So I'll let the first speaker introduce himself. Thanks.
Jack, we will start with the mini survey. I will launch it now, okay?
Yeah, great. Okay, so this is a survey. We're not allowed to vote as hosts and panelists, but you'll all get to vote. If you have a mobile, this may or may not work depending on the type of mobile you've got. I've been assured that we've done everything we can. So hopefully those of you who can vote are able to. But we'll just give you a couple of quick questions to go through these starters and see how you go. Okay, Katerina, I might get you to put the results up now if you can. Okay, so this is a much more interesting spread than we usually get for these workshops. So it really does show that there's quite a difference in what's happening across global settings. So for high protein and high energy foods and fluids within 24 hours of surgery, um, it looks like round about just sneaking in over half of participants think that this is offered half the time or more. But there's still a reasonable amount of people who are either not sure or um, almost exactly one third of participants who are pretty assured that this happens less than a third of the time. Additionally, when it comes to offering oral nutrition supplements within 24 hours of surgery, it looks like it's again a bit of a mixed bag. So, uh, yeah, that it does definitely show that there's some differences probably across sites within hospitals, within countries, and also across countries, and that's something that we seem to pick up from some of the other surveys we've done as well. So, yeah, I'll hand it over to the next person to go from there. Thank you. And Julie, I see I've got five people sending me the planner, but my organization is blocking it for some reason. It won't let me see the planner. It must have something in
All
it
right.
that's considered inappropriate. So I'm going to need you
Sorry,
to just
I'll
tell us
help you
what
out
next.
then. So
Yeah,
Paula's the next speaker, I think. Is that right, Paula? Are you ready? Cool.
Yeah, thank
great.
you.
Cool. Thank
So
you.
go take it away, Paula. I'm a bad chair at the moment. I don't know what I can do. It just keeps getting blocked from my organization.
All right. Well, don't worry, Jack. I'll just sort of like handle the agenda, and then we can you can just relax a little bit.
Perfect. Thank you.
Okay, so good afternoon or good evening, depending on the on which part of the world you are at this moment. Well, my name is Paula. I am a clinician and I work with perioperative medicine in Brazil and also with clinical nutrition. And today I want to present some important information about simpler, especially in terms of high protein foods and fluids. We know that foods and fluids that are high in protein and energy help build and repair muscle and bone, prevent complications, and support recovery. Older adults after hip fracture surgery often consume very little protein from food and also from fluids. It's important to note that 9 out of 10 patients, 90% of the patients, do not meet their minimum requirements. But we have some options to help these patients to increase the intake of protein. So, high protein foods are meat, poultry, eggs, fish, seafood, soy products, dairy, nuts, seeds, legumes. Like beans, lentils, and chickpeas. Here in Brazil, it's very usual to eat beans, rice, and beans, which is a good source of protein. And if necessary, protein bars and protein powders. There are also some high protein fluids like soups. We can add protein like a grounded meat or grounded chicken, for instance. Milk drinks or fortified dairy-free alternatives. Sometimes I recommend milk, 1 glass of milk with 2 spoons of milk powder, and the other people in general they like it. Um, and some homemade protein shakes or smoothies, breakfast drinks with added protein. So there are lots of options to suggest to our patients. Who should receive high protein foods and fluids? Uh, Actually, anybody with a recent hip fracture, all of the patients, they should be offered high protein foods and fluids until they are assessed for the risk of malnutrition. And for all these patients, of course, if they are able to eat and to drink enough to meet their needs. So for all of them that they are not able, we need to offer a high protein and fluids with high protein source. And also, anybody else screened for at risk or with the diagnosis of malnourished, they will benefit of having high protein foods and fluids, even if it's other fragility fracture different from the hip fracture. And why can we can assess if what we are suggesting or planning or doing is really happening? We can audit like 10 charts or 10 medical or nutrition records documented and see if there is evidence of provision of high protein energy foods or food choice. We can also ask to 10 patients, like, are you receiving high quality, high protein foods and fluid choice? Of course, that we will give them examples of this kind of protein. And has anybody asked you how much you have been eating? So there are some simple questions that can help us to verify if what we are recommending is really been implemented. And also we can survey 10 clinicians or dietitians. What proportion of hip fracture patients have received high protein foods and fluids and have had their intake assessed within 72 hours of surgery? So the simple questions that can help us to get this important information. So this is my first presentation. And now, the next presentation, we will talk a little bit more about why it matters now. The why behind the nutritional, the importance of these nutritional interventions. Our first question, why it matters to our patients? First, offering high protein foods and drinks improve physical and functional outcomes. Higher protein intake, higher protein intake is linked to better mobility, improve functional recovery, and helps the patient to meet rehabilitation benchmarks faster. And also, higher protein intake leads to fewer complications and shorter stay. Adequate protein and energy intake will help to reduce complications, reduce infections, and shorter the hospital stay. And also to maintain the better nutritional status as possible. Low protein intake is not good, and it can lead to muscle loss, worsening the malnutrition status. And if we give adequate intake, if we offer adequate support of protein, it will help maintain nutritional status during this recovery moment. And also, high protein food supports wound healing, immune function, reducing infections, and helps recovery after surgery. Why it matters to our patients? Protein is the key factor, one of the most important strategy to improve the early mobilization. When a patient intakes sufficient energy and protein, it will contribute to early mobilization. It will support sitting, standing, and walking. There are key recovered milestones after hip fracture. Also, high protein foods will help maintain and rebuild the muscle, because after the trauma, they will lose in this phase of metabolic stress response. there will be some muscle loss, and protein can help to rebuild it. And so this supports strength, mobility, and then independence after hip fracture. Early mobilization, as I mentioned before, is a key point for all of these strategies. Patients who receive enough protein and energy are more likely to sit, stand, walk sooner after surgery, and they will get their independence easier than if we do not offer high quality diet for these patients. And also it impacts in the healthcare workers, the hospital healthcare systems, because lower protein intake is associated with higher complications rates, increased demands on care, and this will increase the clinical workload on the healthcare professionals. If we delay mobilization, we will need greater physical, we need great staff participation in assistance, in manual handling these patients, and this will add staff workload. And also, if we delay in the rehabilitation and discharge, because the patient has this moment poor nutrition intake, we will slow the recovery, we will delay the discharge planning, and again, lots of workload on the staff. We also will face reduced bed availability, and we know, especially in development countries, that bed availability is like it's very, very important for the hospitals. And reducing poor nutritional intakes will favor longer hospital stays, limit bed capacity, and will decrease the patient flow. And this will also impact on care quality and team confidence, because inconsistent nutritional care will reduce the quality of the service offered to the patients, and the team will be not very confident. And of course, it will affect the performance and safety indicators, because poor nutrition related outcomes like infection, like longer length of stay, will negatively influence quality metrics. If we can summarize this impact on the healthcare workers and hospital, we can say that if we don't offer adequate protein and energy for these patients, they won't get their mobilization, their early mobilization. They will have much more complications, and this will increase length of stay costs because they will have prolonged hospitalization. They will have higher treatment costs for complications, like treatments of infections, of thrombosis, and it will increase staffing resource use. We will need greater care needs, we will need more staff time and workforce, and it can lead to readmissions and ongoing care costs. So poor recovery increase the likelihood of readmissions and long-term healthcare needs. The inefficiency of the use of hospital beds, that reducing this patient workflow, the flow of these patients will lead your hospital to be inefficient in the bed of utilization, and will have a wider health system burden. So all of this will contribute to increased demand on community and social care service, and all of this because these patients, their evolution after hip fracture was like poor nutritional status, losing muscle mass, losing their functional capacity, And we need to think about all of this, not only for the patient, but also for the healthcare care systems. Uh, and we can understand that protein support with high fluids, high protein fluids and food will help us to improve the quality of care for the patients and also for the hospital. Thank you.
Thank you, Paola. For those of you who've been on for the previous sessions, you'll probably observe that some of the things we've been saying are almost feeling like they've been repeated. That's not because we've just been recycling the same information, but it's because nutrition care for people with hip fracture and other fragility fractures can't just rely on one thing, and there's more than one thing that can make a difference to all of the things that Paola was just talking about. So, for example, whether it's about avoiding unnecessary fasting, making sure people are aware of their nutrition risk status, whether they receive information or whether they receive high protein energy foods or fluids or supplements. And in future webinars, we'll be focusing very specifically on post-discharge nutrition care plans. But in the meantime, we'll talk about high protein um, and oral nutrition supplements today. It's worth noting that all of these things are important because they all impact the things that Paola was just talking about. And so it does feel a little bit repeated, but you're getting the same take-home message, which is nutrition is a strong predictor of poor outcomes, and we can do something about it to make a difference. But there's not just one thing, it's a lot of different things. And there's 6 key things that we tend to focus on in Simpler. And so, with that in mind, I will pass over to Julie, who is going to present a patient scenario. Thanks, Julie.
Oh, hi everyone. Please forgive me. I'm having a little trouble with my the quality of my internet connection this afternoon, so I've switched my video off, but I am still here. So Katerina's just going to load up for us a patient scenario for us to have a think about for a few minutes. Paola's very kindly taken us through some of the principles of this issue around protein intake with our hip fracture patients, but sometimes it really helps to apply this to a patient scenario. So here we go. Have a think about this. Mrs. K is an 82-year-old patient and she's admitted following a hip fracture. And she's now on the post-operative ward having had her surgery. She appears tired. She has mild pain and has eaten very little of her lunch. And of course, you've noticed this. And when you ask her about this, she says, I'm just not hungry. I'll eat later. And I'm sure for many of you, that's a really common problem with these kind of patients when you're trying to get them to eat. So Mrs. K is at high risk of low protein and energy intake, both of which are going to be essential to her recovery, due to poor appetite and fatigue, which of course may delay her recovery and increase complications. So which of the following things do you think you should do next? Should you take her lunch tray away? It's only day 1, so perhaps she should be on clear fluids. 2, respect her wishes and remove the tray so that she can rest. Or would you reposition her, explain that protein is important for recovery, and ask if she knows which foods are higher in protein? So we'll give you a couple of minutes to have a bit of a think about and respond to choosing one of those 3 options for this patient scenario. You can hear all the cogs in the system working away in the background. Hear everybody clicking. We haven't got quite as many people here this afternoon as we had this morning. I'm talking about afternoon in the UK and this morning. So we might get the results in a little bit quicker than we did earlier on today. Of course, Vicky, I'll say the options again. Would you take the tray away? it's only day one, so she should be on clear fluids? Would you respect her wishes and remove the tray so that she can rest? Or would you reposition her, explain that protein is important for recovery, and ask if she knows which foods are higher in protein? If I could copy and paste them, I could put them in the chat for you, but it won't let me do that. Maybe we need to think of another way of doing this. So.
Perfect timing, Vicky. I see you've put the answer in the chat for us there already. So maybe Katerina, if you're able to
Oh,
pop
thank
the
you,
result.
Melton. So Melton's actually put the questions in. Thank you very much. Good stuff. Okay, so most of you, 89%, went with the correct answer, which is reposition her, explain that protein is important for recovery, and ask if she knows which foods are higher in protein. Because one of the problems is very, very much in this area of practice that we we were talking a lot about giving patients information and how that's important in the way that they react to the nutritional care that we give them. And what's central to this is her understanding of why protein is important, and why, even though she feels tired and not very hungry, she needs to be eating these extra protein and calories here. I don't know if you wanted to add anything to that, Jack.
All I'll add is while you're getting your slides up, before I introduce you for the next session, Julie, which I won't because we already know who you are. I will just say that, yeah, look, it, we have a knowledge to practice gap. It's very clear because you've all answered the right answer, well, mostly. And we've found that with many different surveys we've done of health professionals over the last few years, where we generally do know what it is that we should be doing, but it's not happening. And so I'll introduce what Julie's going to talk to us about now to encourage us about sometimes when we know what to do and we just can't do it for some reason or it's just not happening. Giving people more information or education usually doesn't help. You need to think about people's motivation or their capability or the opportunities, apart from just education, that can help change practice so that we close the gap between what we know should happen and what actually does happen. So as Julie's going through these slides, have a think about for your team and for your setting what things Julie's talking about might actually help your team to make a difference. And if there's something that you see that does sound good or something that you're already doing, please, I encourage you, do put them in the chat because it would be great to hear from others about what's happening or what you're struggling to actually change.
Sure. So, okay, let's have a bit of a think about this because the whole tenet of the Simpler program, Better Nutrition, Better Outcomes, is about helping clinicians and all of the other folk who they work with to think about how they can improve and take practice forward in this area. And some of those things are relatively simple and some of them are a little bit more complicated. But you can build up gradually over time to making a real difference. If you think about how do you improve that whole idea of patients receiving high protein foods and fluids in practice, and what, who, when and where can you help and make change happen? So starting then with what helps to improve making sure that patients receive high protein foods and fluids. Well, the first principle is start early. Start high protein foods and fluids from diagnosis. So by that we mean potentially even before someone leaves the emergency department, but certainly in the preoperative period, because there's often a period there where patients are still are receiving care. that we're avoiding necessary fasting, but we should be making sure that while they're not fasting, they're getting the best nutrition that's going to set them up for a really good post-operative recovery. And there's loads of research that shows that if you supplement patients with high protein supplementations before surgery, then that can make a massive difference to their recovery post-operatively. We can provide high protein foods and fluids as part of routine hip fracture care. Nutrition is such a fundamental part of hip fracture care. If we get that right, we're often getting all of the other bits that we're looking at right as well. So what we need to do is we need to make high protein, high energy menus, meals, snacks and fluids the default for all hip fracture patients at every eating opportunity, just so that we're getting this very clearly embedded in everything we think about and everything we do with these patients. So to help us with that, we can optimize meal design and timing. So we can align meals with patient routines, which sometimes involves being a little bit more flexible. We can reduce interruptions when patients are eating, but at the same time, encourage those who might help them to eat to be there. And we compare protein intake with mobilization or therapy, for example. And I'll come back to that idea about mobilization and therapy and protein intake in a few moments. Improving food services and access is really important, making sure that everybody can access high protein, appropriate and culturally relevant foods using systems that are flexible, that work around patients. So well-stocked pantries and fridges and staff supported ordering, because the staff are the ones who know best what it is that their patients need. And the other thing we can do, and Paola's already alluded to this, is monitor intake and act on any barriers. So we know what patients are eating and what they're not eating, acting when we know that that's low, and addressing the problems that are stopping them from eating, and escalate that further up the chain if we need to. So how can we improve this? Well, it's been shown that embedded nutrition into care pathways and systems really makes a difference. So by including high protein nutrition in care pathways that are supported, by example, with electronic medical record prompts, things like visual cues, posters, signs, and embedding it in routine care processes, that can make a real difference. The whole multidisciplinary team thing, which is also something on which this programme, a tenet on which this programme is built, means that we can share responsibility across the whole team, so that it doesn't become something that's, a particular responsibility of one particular team member, so that we're involving all staff and family carers, volunteers and local champions. Of course, education is important, and the reason that this programme is going to be so widely available, and Jack will talk a bit more about that in the end, is so that these simple, consistent messages to explain, support and reinforce high protein intake throughout care can be used by everyone out there when they're providing care to patients. And having data about what's happening can be really, really important. So measuring, auditing and having feedback about intake, key measures and sharing results and recognising improvement can be really quite central to that as well. But there are some quite common challenges, and I'm sure that the discussion that we had this morning, people were very much talking in the chat about some of the problems that they were having regarding making sure that patients had high protein, high calorie food and fluids. And I suppose a big one of those is confusion or delirium. And it's really important with patients that we've identified as confused or have delirium, that they have supervised, supportive meal times with prompts that encourage them to eat what's in front of them, because when your thinking processes aren't working properly, it's really hard to do that. And so the important thing about that is that someone has clear responsibility for assisting those patients, and that might be something you might want to discuss among your team. A lot of people talk about patients having poor appetite, fatigue, or pain, which was the example in the case study that we just talked about just now. And by offering small, frequent, high protein options, managing pain before meals, and using supplements if they're needed, we can ensure that intake is accessible when patients feel best. And again, for those that have difficulty chewing or swallowing, we can provide appropriate textured, high protein foods, assist them with positioning and feeding. You know, nobody wants to eat anything if they're not in the right position to eat. One of the reasons why we like to get patients out of bed to eat as much as possible from early in their care pathway is that they're then in a much better place to eat and drink. Perhaps patients or staff members don't understand why protein is important, and having this constant message coming from everybody that's simple, repeated explanations and clear written or visual materials is really, really important. Perhaps the patient can't sit up or eat independently, or they decline high protein options. And a lot of patients do find high protein foods and supplements quite difficult to eat, and they may actually not like the flavors or anything like that. So what we need to do, and you know, from a nursing perspective, I know that this makes a really big difference to all sorts of things to do with patient care. We need to prioritize upright positioning and feeding support, and coordinate that with the therapy that the patient might be having, explore their preferences, and very importantly, explain the benefits of this high protein food and fluids very simply, and use encouragement that's consistent. And you know, where service nutrition is not a service protein priority and high protein foods and drinks are not available, this is something that's, you know, it's really important to tackle this. And in order to do that, staff who are acting as advocates for this idea can highlight how outcomes and costs to elevate nutrition as a priority and embedding it in policies, ensuring that high protein options are the default, is really, really important part of moving things forward. So in terms of who can help improve the patients receiving high protein foods and fluids, of course it's everyone, but there are some quite specific parts of this development of clinical practice that lie with some maybe specific members of the healthcare team. So orthogeriatricians, surgeons, junior doctors and other medical professionals can be very proactive in actually prescribing high protein diets and supplements, because what that does is it gives it really high priority so that you can prioritize nutrition as actually part of medical management. And it's getting that over to everybody, is that nutrition is a really important part of the patient's treatment in their recovery, and reinforce the link between protein recovery and reduced complications. If a consultant surgeon or a geriatrician or even a more junior doctor is telling patients the reason that they need to eat more protein is that it will improve their recovery and reduce their complications, they're very likely to listen to that. Nurses are there 24/7 in hospital settings, so they're going to be very useful at identifying those patients that are at risk, monitoring intake and recognising concerns so that they can be escalated and additional support sought. They can, again, like everyone, provide and explain high protein meals, snacks and drinks, ensuring that patients actually receive them and that they're given the support that they need to be assisted at meal times so that we can improve nutrition access and practices. Physios are so central to this because we know that protein and calories make a significant difference to patients achieving their rehabilitation goals, and we can link nutrition to that. So encourage them to think about protein for recovery and reinforce those simple messages while they're having therapy. Speech and language therapists can help with swallowing and adapting food textures. balancing safety with making sure that patients get adequate nutrition and hydration. And of course, dietitians and nutritionists, where they are available, can help with assessing high-risk patients and supporting things like high protein menu planning and providing specialist nutrition advice. Healthcare assistants, I always think, are really quite central to this, because those are the people who are actually at the bedside with the patient during times when they are eating. And they're really very central in providing feeding support, ensuring safe positioning and helping patients access their meals. And everyone else needs to make sure that we're actually giving them the support that they need to do that in a supportive environment. And of course, support services such as catering, food services and volunteers are very instrumental in helping us to deliver appealing high protein meals on time with fewer interruptions and assisting with feeding where appropriate. And of course, this isn't just something that clinical team members are involved in. Administrators and executives, food service managers and support services, quality audit and IT teams, educators, clinical leaders, patients, carers and advocacy groups, and even professional organisations and researchers, just like those of us within the Fragility Fracture Network, can all be working with those clinical teams to make sure that this nutrition, the importance of nutrition, and in particular making sure that patients receive high protein foods and fluids, is working throughout the system. So making sure that the systems enable easy ordering, access to high protein foods and drinks, providing options at all times with flexible access to kitchen facilities, pantries, fridges. Audit can really help to give us data that helps to let us know that nutrition care's improving, and as a consequence, so are the patient's outcomes, and better nutrition is making a difference to that. And that works the same with everything from that point of view, right through from training, making sure that we understand patient and experiences, and promoting standards and guidelines. And when, well, throughout the whole period, really, but there are some parts of the patient pathway that really make this, that have specific things that can be happening in them. Pre-admission to a hospital ward is still a good time to make sure that when patients are waiting for things to happen and they are not being fasted for surgery, that we can embed screening in practice, manage pain and prolong fasting, and where patients can eat and drink, they're provided with access to high protein foods and fluids. So that runs right through the emergency department, where things like training emergency department staff, providing access to high protein foods and fluids, and stocking basic meal options for after hours can make a real difference. And this works right through on the hospital ward while the patient's waiting to have surgery. You know, as we talked about in week 1, avoiding unnecessary fasting is important. But the reason it's important is because it means that while they're not fasting, we can make sure that they're getting good nutrition, including protein and calories, before they get to theatre if we deprescribe unnecessary dietary restrictions. In theatre and perioperative care, so this is about reducing time to surgery to avoid unnecessary delays, restarting fluids as early as possible so that local procedures support early feeding after surgery, and also avoiding waiting for things like bowel sounds or flatus before initiating post-operative feeding, bearing in mind that there are some patients for whom that can be a bit of a problem, and it's important to take that into account. But the important thing is the patient needs to be fed as soon as they possibly can. And in the post-operative care, using simple scripts in staff routines and workflow changes to promote protein intake and reduce mealtime interruptions is central, and tracking patient-reported nutrition measures, so whether they've got access to nutrition, whether they were aware of its importance, they've had information, they've got assistance, and outcomes are reported. And we've talked about having pantry and mini kitchen available for everyone who wants to help the patient to eat and drink. And once again, this works into systems, policy and continuous improvement. It's about having everyone on board who understands the importance of making these high protein options the default in menus, care pathways, policies, clinical standards, and embedding those systems to support using things like audit so that there's lots of data about quality improvement and closing those gaps that Jack was talking about just now. And I think it's really important to remember that many patients who've sustained a hip fracture these days and had surgery are actually discharged from hospital really early in most places these days, and they still have care needs. So there'll be transfers between care settings, and it's really important as patients move on to the community or to another care setting that nutrition status and plans are included in referral documents, and that communication works really well with ongoing care teams. They've got written guidance on high protein foods, and it may be necessary to support post-discharge nutrition through meal services. And there are really some good community support and stuff like that. There's some examples of really good practice going on around the world as well that shows that really makes a difference. So I will leave it at that, and I will stop sharing my screen, and I will hand you back to Jack.
Awesome. Thanks, Julie. And if anybody does have any examples of either post-discharge, high protein, high energy support for people after they go home, or just even meal support in general that's happening, I'd love to hear from it, because it's an area that we're not doing particularly well in globally. And as we get into the the oral nutrition supplement section now, if anybody's doing the same thing where they're continuing those through after people leave hospital, if you could just pop that in the chat if you're happy to, and just tell us how you're making that work, or just even if it is happening. I'd love to know if anybody's doing that. I'll now hand over to Sathira. So Sathira, I'll get you to introduce yourself, but I'm delighted to have Sathira with us from Sri Lanka, who's going to talk to us about receiving about oral nutrition supplements in general. So he's got a couple of short presentations that he's going to present now. Thanks, Sathira.
Thank you very much, Jack. And again, good morning, good afternoon, and good evening for everyone joining from all around the world. So I'm Sithira. I'm a geriatrician, especially interested in orthogeriatrics from Colombo, Sri Lanka. And so let me share the screen. Hope you can see my slides.
Perfect. Thanks, Sathira.
Great. Excellent. All right. Okay. So we are moving from high protein to next simpler step. It's about receiving oral nutrition supplements, and we're going to discuss what it is and who should receive it and how to measure it. So let me give you some facts before we discuss about oral nutrition supplements. So we all know that oral nutrition supplements has strong evidence for its effectiveness. But despite the strong evidence-based recommendations, their practice is still inconsistent. And we also saw it in our survey when we started the session. And many patients, due to this, miss key opportunities for recovery support. So due to low and inconsistent practice of delivery of high-protein diet, supplements, and nutrition information. And supplements are essential, especially the cohort we are talking about, the older people with a poor appetite, who are having a catabolic state after surgery, and who are recovering. And so the oral nutrition supplements provide a reliable method of delivery of protein, energy, and other nutrition supplements. So what are oral nutrition supplements? Oral nutrition supplements are they are specially designed food and fluids for medical and clinical use. We need to consider them as medicine for these patients who are having a lot of nutrition problems in this post-operative period. And they are used to increase protein and energy intake as well as other important nutrients. And they typically provide protein as well as the calories as well as the vitamins and minerals they need. They come in different formats, textures, and thicknesses depending on the patient's choice as well as their clinical condition. Probably most of these patients having problems with swallowing, problems with chewing, and a lot of other problems. And so they come in like powders, soups, bars, desserts, and many other forms as well as tastes. And come in different strength and concentrations as well, depending on the patient's need. Then they may include added ingredients to support recovery, not only the basic calorie and protein, but also can have some other extra nutrients such as beta hydroxy, beta methyl butyrate, leucine, amino acids, omega-3 fatty acids, and extra nutrients that will help recovery. Okay, who should receive oral nutrient supplements? First of all patients with hip fracture should receive oral nutrition supplements. So we'll see why. Up to half of patients with hip fractures are already malnourished when they get a hip fracture. And most do not meet their protein and energy needs because of many reasons. And malnutrition screening tools often they are not very effective in these patients due to multiple reasons. They may be confused, they may be in pain, and there are a lot of communication barriers with older people. So due to many reasons, these malnutrition screening tools, they don't work very well. So that's why the international guidelines recommend offering hip fracture patients, all hip fracture patients, oral nutrition supplements, regardless of their initial nutritional state. So we like to keep it simpler. All hip fracture patients should receive oral nutrition supplements unless contraindicated. That's what we are going to stress here. And what about the other patients with other fragility fractures? So other patients who are at risk of malnutrition or who are already malnourished should also receive oral nutrition supplements where they are unlikely to meet their protein and energy needs using high protein foods and fluids alone. Right. How can we measure received oral nutrition supplements? Again, the same way. So we can use audits. We can make a audit chart and look at the documented evidence of provision of oral nutrient supplements and assessments taken. And using audit charts, we can see, we can measure about this. And also,
becoming more of a startup like culture, AI, all those
we can ask 10
things.
patients in the same way, especially with a good memory. And because the older patients, they can be problem with recall. Are you receiving oral nutrient supplements, or has anybody explained what these are for and how much of these are you having? So you can use simple questions to ask 10 patients. And also in this similar way, we can ask 10 clinicians what proportion of hip fracture patients have received oral nutrient supplements or had their intake assessed within 72 hours of surgery. So these are simple ways of assessing whether the patients have received oral nutrition supplements. Okay, that's about the first part of the presentation about what oral nutrient supplement is and who should receive it and how to measure it. So I'm moving to the second part of the talk. It's about why oral nutrient supplement matters. Okay, I think we went through some of the details why oral nutrition supplement matters even in the first presentation. So we'll stress more about these steps in this presentation. So oral nutrient supplements aid faster recovery. Higher protein intake and energy intake helps maintain muscle function and they support short hospital stays and rehabilitation stays. And the patients, elderly patients, so they are at risk of other complications of malnutrition, such as increased risk of delirium, increased risk of infections, and giving oral nutrition supplements will reduce delayed wound healing and will reduce poor rehabilitation outcomes and overall will reduce the mortality. And what about the long-term recovery? So ongoing use of oral nutrition supplements support functional recovery, and in the long run, it will reduce the risk of further decline. And also to stress, these patients who are developing hip fractures, they are in a catabolic state and with higher chances of developing muscle mass and poor appetite and inflammatory state that's going to continue and slows recovery and increases the complications even after surgery. So oral nutrition supplements ensure they get enough nutrients, including calories, proteins, and other micronutrients, and help to avoid this catabolic cascade. And when it's come to healthcare workers, hospitals, and healthcare systems, why giving oral nutrition supplements matter? So if you look at the organizational impact, it can increase the team effectiveness. So including oral nutrition supplements in structured pathways, they improve communication, reduces confusion, and it also strengthens the teamwork and supports more consistent care delivery. And if you provide oral nutrition supplements, patients recover faster. So they reduce complications, reduce duration in your hospital and the rehabilitation units. So that improves the patient flow. And also, it improves the quality and compliance. Oral nutrition supplements use supports adherence to fracture care and nutrition guidelines, improving care quality and standardization. And also improve system integration. Coordinated nutrition strategies enhance multidisciplinary collaboration and standardize care processes. Not only about the institutional level, it also has huge economic impact. So it reduces complications, it makes fewer infections, fewer pressure ulcers, and other nutrition-related complications, and lower treatment cost and resource use. And again, I want to stress about shorter hospital stays. So it accelerates recovery, decreases length of stay, freeing beds and reducing hospitalization expenses. And of course, it reduces readmissions. Effective malnutrition management with oral nutrition supplements has shown to reduce readmissions, especially in high-risk patients. This cuts costs for the health system, and it makes a cost-effective intervention to provide oral nutrition supplement. It's a financially efficient way, providing better outcomes without increasing overall healthcare expenditure. So that's all about the oral nutrition supplements. I think we can move to the discussion. Thank you.
All right, thank you so much, Sathira. I got a little bit sidetracked answering a great question from Annie Matthew in the question list. So I am working on that response there. In the meantime, I'd love to now introduce Melton, who's going to go through with the patient scenario. Thanks, Melton.
Thank you. Now we will be sharing a patient scenario. Actually, I kind of spoiled it while trying to share the previous patient scenario. I shared this one by mistake, but that I quickly changed it. Now we have this scenario. Mrs. T, an 82-year-old woman, is recovering from hip fracture surgery. She's struggling to finish her meals and often refuses her prescribed oral nutritional supplements. Her daughter provides most of her support, but is unsure why ONS matters. Staff have been inconsistent in reminding her to take them. You need to decide the best action to improve Mrs. T's nutrition intake and recovery. To your opinion, what is the most appropriate next step to improve ONS adherence and support recovery? The first option is asking Miss T if she would like a dietitian to review and change the flavor. The second option is increase meal portion sizes to replace ONS or nutritional supplements, since food alone should meet her needs after surgery. And the third option is providing clear, consistent explanations to both Mrs. T and her daughter about how oral nutritional supplements supports strength recovery, reduces complications, and is part of evidence-based hip fracture care. Then ask if she would like to include it as part of her treatment. Treatment plan. Yeah. In the chat, we have some answers as option 3.
And I've put, while people are still finishing off this question, I have put a quite detailed I guess, case study from a single site, which is our hospital, in response to a question about protein and energy restriction. This often brings up a lot of conversation around whether or not, for example, people with chronic kidney disease, whether or not we should be restricting protein or not offering oral nutrition supplements. All I'll say is in my hospital and in all the hospitals I've ever worked, if I have a multi-morbid older person post-surgery who very, very rarely meet their energy requirements or their protein requirements, I've always approached my doctors, my treating doctors, and asked them, do you want to restrict this person's protein intake? And they usually laugh at me and they say, no, we need them to eat enough to look after their muscles. Yes, we need to look after people's kidneys, but we also need to look after their muscles. And when we know most people aren't going to eat themselves into acute kidney failure, it's okay for them to have the protein. But that's what we do in our hospital. But what happens in your hospital, I'd suggest checking with your own team.
Yes, about the patient scenario, we have the answers. Most of you have selected the third option. Of course, changing flavor or food fortification, increasing portion sizes can be some strategies to improve the nutrition overall, but it won't replace the benefit that we are expecting from ONS. So we need to first explain the information, evidence-based information about ONS, and so it would be a better strategy to follow.
Right,
So
thanks,
now I
Meltem.
will.
I'll get you to open up your
Please,
slides
please.
and there we go. That's good.
Okay.
We can see that.
Now, great. Now, in this part of the webinar, we will be talking about how to improve our practice to have better results for the step of received oral nutritional supplements in this simpler approach. What helps, who helps, and when and where change happens. First of all, we need to focus on the common challenges to improve our practice. There are different levels of barriers against the received oral nutritional supplements step. First one is ONS-related barriers. So we need to define and expand what counts as ONS or nutritional supplements to suit local context and patient needs. And we need to ensure ONS are accessible at all times and consistently stocked on the ward. And we should allow different members of the team to order, prescribe, or provide ONS. It shouldn't be a responsibility only one person in the team. And we should align funding and systems to make ONS available in hospital and affordable after discharge. If we come to the team level barriers, we need to clarify roles and empower staff to act and integrate ONS into routine workflows and care pathways. It's really important to standardize practice by offering ONS to all patients, prescribing as treatment, and linking to rehabilitation. It shouldn't be a rare option or something that we may have in our mind in certain patients. It should be standard for all patients with frigidity fractures. And it's quite really important to improve the team communication, to give consistent shared messaging, and to educate our team, and to construct role modeling. If you look at the patient level barriers, it's important to improve understanding and engagement through clear information, shared decision making, and linking ONS to patient goals. And it's also important to support access and intake with assistance, symptom management, simple routines, and supervision when needed. And we should empower patients and carers to request ONS and use prompts, reminders, and encouragement to maintain intake. When we look at the systems, policy, and funding barriers, it's important to establish standard pathways, policies, and default ONS prescribing processes. And we should embed prompts and documentation for ONS use and intake in workflow and IT systems. And we should use audits, feedback, and recognition to build ownership and improve performance. Who can help us to improve to improve the received ONS step of simpler approach? The quick answer is everybody in the team. But if we look at one by one, doctors have a really important role here, because they act as trusted sources and role models. So they should reinforce nutrition and ONS as essential for recovery. And they should embed ONS into routine care by prescribing early, continuing at discharge, and aligning with guidelines. And they need to support consistent practice and improvement through holistic care planning, audits, and leadership. If you look at our nurses, they have also a crucial role, because they are spending much time than other team members with patients, so they have this opportunity to improve our practice. They should deliver ONS as part of routine care, monitor and document intake, tolerance, and barriers. They should encourage and educate patients while providing continuity across shifts and care settings. And they can escalate concerns. They should escalate concerns and support ONS as medicine within the multidisciplinary team. Allied healthcare professionals, these include pharmacists, occupational therapists, physiotherapists, nutritionists, dietitians, and other members of the team. They also have a responsibility here. They have opportunity to improve our practice. They should provide or support ONS use, reinforce its role in recovery, and integrate nutrition into routine care and therapy. They should encourage intake during rehabilitation, identify patients needing extra support, and escalate concerns. And they should support coordinated team care with dietitians managing complex needs, guiding plans, educating staff, and contributing to improvements. Healthcare assistants and catering teams. This is also an important opportunity to improve the practice of delivery of ONS. They can support ONS intake at bedside while they're contacting with the patients. They should encourage them and monitor and report intake or adherence issues. They can provide day-to-day observation to identify and escalate low intake or refusal early. And they they can help to ensure timely, accessible delivery of ONS and coordinate with teams to reduce barriers and support routine care. If we look at the funders and leaders and managers, they should help to set standards and embed ONS into policies, pathways, and systems and culture as routine care. And they need to enable access, funding, monitoring, and scale up through infrastructure, audits, and leadership support. So when and where can improvements happen? Where should we expect these improvements to be seen? Again, the quick answer is from the start of the care pathway till the end and beyond after the discharge period. On the pre-admission stage, nutrition screening should be included in pre-admission clinics, and ONS should be integrated into perioperative and transfer pathways. Subsides or free ONS for patients should be provided because some patients are really unable to meet needs through food alone here, as well as also in the pre-admission phase of the care pathway. And also at this stage, we should support acceptance through clear explanation to patients and carers. In emergency department, it's crucial to train emergency department staff on nutrition or nutritional supplements, unnecessary fasting, and all important tips about nutrition. So ONS is one of them as well. So we need to embed screening and documentation of nutrition risk, and we should include prompts in systems and handovers. And we should enable staff to prescribe and provide ONS, support early initiation and monitoring, and optimize pain, delirium prevention, and fasting practices, because they also are really important barriers against both against good nutrition or sufficient nutrition, and also intake of oral nutritional supplements. At the theater and perioperative care stage, we should ensure handovers include nutrition risk, prior ONS use and plan, and access to ONS in recovery areas should be provided. And ONS should be included in postoperative orders or recovery plans. In the postoperative ward care phase of the pathway, ONS should be continued as routine care, and it should be integrated into daily workflows, and it should be monitored and documented accordingly in terms of intake and adherence. We should define roles and train our staff, our team, to manage barriers and use consistent team messaging to support oral nutritional supplement use. And additional patients needing oral nutritional supplements should be identified, and patient-reported nutrition measures should be collected and reported periodically. At the systems policy level and for the continuous improvement, ONS should be embedded into pathways, policies, order sets, and IT systems to support prescribing, monitoring, and documentation. The intake, adherence, and outcomes should be tracked using audits, standards, reporting, and care bundles, because data is really important to showcase our gaps or success. So these data should be collected through feedbacks, incentives, and local champions. And transfer between care settings, this is a really important point, because while changing the settings, some of the care plans are being lost somehow. So we need to strengthen this part. Planning post-discharge nutrition care with patients and carers is really important, and it should be including clear instructions and support even after discharge. And we should ensure continuation of ONS where indicated and effective handover to primary care and community services. And access, follow-up, and supply pathways should be improved to support ongoing intake and adherence of the patients to oral nutritional supplements. That was the end of my presentation.
Thank you
And
so
thank
much,
you.
Milton. And again, there's some great things hiding in there about different ways in different places in the world people can actually improve that knowledge to practice gap so that there's more people who need to receive oral nutrition supplements actually getting them. So if I can get you, Katerina, to put up our next knowledge quiz. Now, we don't actually get the results back from this quiz, the way the quiz works. So we will leave it open for a little while, but after about 2 minutes or so, I will start on the next presentation to make sure we finish on time. So because there's a number of questions, I think we've got 6 questions. I won't read them out. So apologies for those who have mobile phones or can't access these or answer them. But that's an opportunity for me to give some free advertising for our simpler module, which contains the 6 units based on the simpler 6, which are available, which we will show the link for at the end of this webinar again. But you can actually get the information you've heard here and more online any time of day or night, and get yourself a number of quiz questions that you can answer. And there's also some other interactive activities within those education modules as well. So I hope I've done a reasonably good positive sell for the hard work that the whole team have gone into to develop these modules. So again, thank you to all of our global members of the Simpler team that we have, all of our regional supporters who have helped to pull together these learning units. So I'm hoping it's the same for your platform as mine, but I do know I can usually see the questions still when a new PowerPoint opens. So I'm going to take a risk at the risk of people then being kicked out of the finishing your questions. And if that does happen, I do apologize in advance. But if not, you can keep completing the questions while I move on to the final section of slides. So Katerina, if you're able to share the slides for me for the next section, that would be great. Perfect. Okay, so thank you. And apologies, I'll have to ask Katerina to advance the slides for me. I'm currently not in Australia. I'm in Norway at the moment. We've been having some delightful conversations with hospitals from a number of different places in Norway, and as well the Fragility Fracture Network. Norway has just launched their revised hip fracture care standards and guideline, and that now definitely includes a large centerpiece around nutrition care that is based on Simpler. So it's really exciting. A number of countries now are really taking this on board and including nutrition as part of their hip fracture care standards and guidelines. So well done, Norway. Thank you. And thank you for having me. It does mean I'm feeling a little lost though, because I don't even have a mouse at the moment and I hate track pads. So I'll now be talking about the simplest steps to improvement. And for those who've been in the previous webinars, you will have heard this already, so I'll make it reasonably quick, but it's just a good way of doing things so that teams can work together to drive change. And it's not research, it's based on the model for improvement. So it's simpler. So next slide, thanks. I'm shifting the forward button and it's not working, and that's because Katarina's got the slides. So firstly, form your simpler team. And the team does not need to be a whole lot of experts, and it does not need to include lots and lots of people. And it probably doesn't even need standard minutes or note takers or anything. It's best done, again, as I've said previously, with just a group of motivated people who can sit down and have a coffee or tea together and some cake and talk about what can be done to make things a bit better and a bit simpler for nutrition in the ward where you work. So next slide. Then, as a group, go, who should actually receive high protein foods and fluids, and who should receive oral nutrition supplements? In many places around the world now, hospitals are going, this should be everybody who's had a hip fracture, unless they're not allowed to eat or drink for some reason, if their gut's not working. And if people need texture modification, for example, they've got swallowing difficulties, many settings have appropriately textured alternatives that are also high in protein and for oral nutrition supplements. So I would say anybody with a recent hip fracture, but that's for my hospital. Your teams get to choose who does this, and also who can provide or prescribe them. And then anybody else who's screened at risk of malnutrition or diagnosed as malnourished. And you'll see down the bottom I said, who are approved for oral intake and do not require specialized diets. So that's just the caveat. We still have to realize that these are guidelines, and guidelines, there's always an exception to the rule. Okay, next slide. Thanks, Katarina. Then set a simpler aim. For example, within 3 months, half or more of our hip fracture patients will receive high protein foods and fluids and oral nutrition supplements within 24 hours of surgery. Now that can be either before surgery or after surgery. And some teams might make it a little bit longer than that, depending on your processes, but it can be done, and many hospitals are doing it in that time frame. But that's just an example. Again, your simpler team should set your own aim. Next slide. Thanks, Katarina. Test, choose, and collect simpler measures. I'm not going to go through these because you've already heard them, but it's again, audit 10 charts, ask 10 patients with a good memory, or survey 10 clinicians. But I will talk to the one that is my favorite, which is, has anyone or anybody explained what these are for? Yes, we might be providing high protein foods and fluids. Yes, we might be providing oral nutrition supplements, but all over the world, most people who receive oral nutrition supplements and high protein foods and fluids do not know they are malnourished, and they do not know why they are receiving them. And so, of course, they don't eat or drink them nearly as much as perhaps what they could if they knew that they had a very harmful condition, and if they knew that the treatment actually improves their outcomes and reduces their complications. So that to me is the most important question. Just go around and ask 10 of your patients who are on supplements or on a high protein diet, has somebody told you what your nutrition status is? And do you know what the supplements are for? You might be quite surprised in a negative way at what the answers are. Okay, next slide. Thanks, Katarina. And then finally, select, test, and implement changes. I'm not going to go through all the fine print down there, but again, if you log into our website, you can spend the time as a team to go through some of these. They are strongly underpinned by what sites have done around many different places in the world that is successful, but they are also underpinned by strong implementation science and behavior change techniques. So there's a lot of practice and a lot of theory in these prompts that are written down for each of these simpler 6 actions. Next slide. Thanks, Katarina. And then just review and keep going. Compare your before and after. Learn and adapt. And this is the thing. Not everything works that we think works in healthcare. And if you've tried it a few times and it doesn't work, then don't keep trying. Just try something else. There's many other things that can be done. Or maybe it just needs a bit of a change. And so ask your patients, ask your carers, ask your team, maybe what could we do different so this would be more likely to work? And then pick your next thing. Next slides. Thanks, Katerina. Fiona has put, I'm going to distract myself here and answer Fiona's question after I just do the plug, which is, if you want to improve the number of patients who receive high protein foods and fluids and oral nutrition supplements, don't get complicated. Keep it simpler for better nutrition and better outcomes. Fiona, all I can say to your question, and everyone please look at the chat. Fiona's question is, how do you describe malnourishment to patients without scaring them and also getting them to believe you? I get a lot of, oh, but I eat well, but doctor, I eat vegetables, etc., etc. So I've got a PhD student who's been presenting in a number of these webinars, who is doing her PhD all around malnutrition diagnostic terminology. It's very complicated, and it is locally and regionally and individually different. And so that's about all I can say at this stage. In your setting, it's probably worth having a chat with some patients, having a chat with some care providers, and as a group, come up with what words or phrases or ways of describing this should be done. But what is clear is if you have a diagnosis and if you understand your diagnosis, you are more likely to follow the treatment. So regardless of what exact words are used, we need to make sure, as part of shared decision-making and informed consent, that people understand that they have malnutrition. They receive the information in a way they understand, and then they can make informed choices about their treatment. So next slide. Thanks, Katerina. Great question, Fiona. Thanks so much for putting it in the chat. There's the links which most of you will have seen before that are available on the Simpler Nutrition Global Hub, which even if you Google it, you'll find Simpler FFN and it should bring the hub up, but there's some links down there. Next slide. Thanks, Katerina. I won't go through these for sake of time, so we'll just keep going. I think I've got 30 seconds to finish this on time, so we'll see how we go. While we're waiting for these slides to come up, I will thank our panel again. Thank you, panel. Again, it's been an excellent group of presentations, and I really hope we can see you all next week, where we will be focusing on implementation. What are some of the things that you can do or would love to do or are already doing but want to sustain and scale up in your setting? And so we'll really focus on turning the theory into practice next week. So I hope to really see you there. Next slide, please. Thank you. You'll receive a follow-up email and also the opportunity to complete a survey. And we'd really like you to tell us honestly what you thought about today's session. And so please give us your feedback. And I think the last slide to come after this one is the link to the Simpler Global, the learning module, where you can get this and more information that we've already told you. And then the very final slide is the linked to the global hub. So thanks all. Thanks for your time, and I really hope you can take some of your learnings back so that you can deliver better outcomes for your patients and also your health services. See you later all.
Bye, everyone.
Bye.